Our question is, for a 27-year-old male recreational basketball player that has functional ankle instability in his left ankle, is exercise therapy effective to reduce pain and improve function? So for summary of evidence, the purpose of our assignment is to test the impact of any type of exercise program on active persons with functional ankle instability, or FAI, in comparison to either no intervention at all or any other intervention that looks at whether the results differ in relation to the exercise program outcome variables and qualities. For the design, we had a systematic review, which is level 1. This study included 8 articles, 198 males, 151 females. Most of the studies describe their participants as active in differing terms.
For the procedure, this study evaluated a bunch of criteria such as strength, pain, balance, proprioception, muscle reaction time, range of motion, static and dynamic postural control, postural sway. Isokinetic strength was assessed alone on inversion and eversion muscles. The measures, participants were able to fill out validated self-report instruments. Some really important ones here are the Cumberland Ankle Instability Tool, Foot and Ankle Disability Index, the STAR Excursion Balance Test, and Ankle Instability Instrument, as well as the modified one. The results showed that for physically active individuals with functional ankle instability, exercise programs appeared to enhance their functional performance, as well as decrease their feelings of instability. By incorporating this exercise training, we are enhancing proprioception, reducing injury rates, and improving postural control. It is important that further research needs to be conducted for specific sport populations to establish ideal exercise programs.
So if we're looking at the applicability of the systematic review for a patient, some threats that we found was that there was a lack of studies that they selected that included specific sports that they looked at or defined what it meant to be physically active. This creates a possibility of the populations not being specific enough for our patient who is a recreational basketball player. Another threat that we saw was the outcome measures for each study were not specifically stated in order to be reproduced. This makes it difficult as a clinician to understand what they were truly testing. For example, one of the outcome measures that was used was single-legged balance. For quality of the systematic review, some threats that we saw was that there was no meta-analysis conducted. This means we cannot combine the quantitative outcomes across the multiple selected studies. And due to no meta-analysis, there was no statistical heterogeneity assessed. So there's no way for us to assess the likelihood of the variability between the primary study results to be due to chance. And so now looking at applicability again for strengths, we saw that the study's purpose is relevant to our clinical question. The review does look at studies regarding exercise therapy for people with FAI. And another one was all studies have interventions that are going to be meaningful to our patient. So some of these include balance, proprioception, strengthening, and postural control. Now looking at quality again, the strengths that we saw was that the search was limited to RCTs and CCTs. So having a majority of randomized controlled trials helps decrease the risk of bias within the studies. And another strength was that the Cochrane Collaboration Risk of Bias tool was used to assess any bias. So this is a valid and reliable standard to show that there was an objective, reproducible, and reliable method used to judge the quality of the study.
Clinical bottom line is the study showed that a 6-week program with at least 3 days a week of exercise showed improvements in static, dynamic postural control, reduction of pain, single leg balance, strength, range of motion, reaction time, proprioception, and self-perceived instability. Exercises consisted of dynamic and static balance control, strengthening, and range of motion. These exercise times should have a 5 to 10 minute warm-up and an exercise period of 20 to 30 minutes.